Good morning. So it's great to speak with all of you, and I have to say Taiwan holds a special place in my heart, as I'll show you in a second. So I had a wonderful opportunity to, as Dr. Glavin and I have talked about, travel fairly extensively through Taiwan. So I was, that was a number of years back when I was doing a lot of international travel and teaching, and at that point in time, I was very impressed with what was going on, the desires and the connectivity within the system. So, the little bit I've heard today, you're doing the right things. This is what we're all trying to do, and all trying to do better. So I think the opportunity to learn from each other is a wonderful opportunity. So this is a very young Dr. Bieber. This is. I started in Taipei and worked my way to the very south. I spent a fair bit of time in Kaohsiung. So this is actually in Kaohsiung, having dinner with my new friends there at the university. And another group, this is actually my father. So why this was such a special trip for me is my father, we didn't get to travel very much, but he traveled completely during this trip. And of course, he was the star of the show. What I learned is fathers there really mean fathers. This is a wonderful thing, and he was always at the head of the table, which was a great thing. But again, a lot younger with a lot more hair. Now, this is our final dinner in Taipei, and I would say, the food and the drink and the camaraderie that I experienced throughout Taiwan was just wonderful. It was just a great time. But what I learned about my father that I didn't know in advance of this trip was he doesn't like fish. So in Tainan, when we had to go to the aquarium, and being very respectful, he said, Mr. Senior Bieber, please pick out dinner, and he had to pick out the fish. I didn't know how hard that was going to be for him, much less to eat the fish. So in our final dinner, having had fish the entire time, this is at Ruth Chris Steakhouse. So, again, they couldn't have been nicer. It was a great, this is probably the best steak that he had ever had in his life. And, again, for me personally, to be able to travel with my father was a wonderful experience. This is University Hospitals. It's a template of geographically what we're doing. It covers a lot of geography, and part of why I'm here, I started at University of Chicago many years back. I then spent some time in Pennsylvania in what was an integrated delivery system, Geisinger Health Systems. And, what interested me about Northeast Ohio and University Hospitals in particular was the potential to connect dots. So what we heard talked about, in my mind, with Minister Chu, is really about connecting dots. It's how do we think about care over geography, and how do we think about care over a continuum, from birth to the need for long-term care in our most senior years, and going on into palliative care and hospice care. How do we connect all those dots? So what it interested me, at least geographically, about here was we have a very big city in Cleveland. We have Urban Academic Medical Center, and Case Medical Center. We have a number of suburban hospitals. And then we have more rural hospitals. We have our two critical access hospitals that are quite remote, very small, serving rural areas largely. In many cases, not as ideally connected as what they could be. So when we start to talk about accountable care organizations, it's really about connecting the dots geographically and connecting the dots over the care continuum. So what I want to do is just, and maybe this sets up the structure for the rest of the day, is frame the conversation, the dialogue around, where the challenges and issues are, where we've missed the mark in part in healthcare relative to other industries, and then how we can move it forward through our actions and activities. So at some level, the ACO model, this triple aim model that Don Berwick has espoused, it really is the core of who we want to be. It's about population health, thinking broadly about how we engage everyone, regardless of who they are, what they earn, where they've come from, ethnicity, that we engage all parties, that the experience of care is tremendous. So, I like the fact that, you're looking at, even as you instituted national health reform, what that meant to the people, what it meant to everybody, and where you have challenges, because if you understand when you're missing the mark, you know what to do to hit the mark, or you at least can come up with gap analysis to help meet that. And then the reality is it does cost us a lot of money to do what we do. And it's incredibly complex on the left. All these different pieces and parts that different people run, that different people function within. Even in your conversations about what do we privatize, what do we keep as part of our National Health Initiative, we still have to do lots of bridging between very disparate functions and people with very different visions. So again, when you run acute care hospital, which I do, and when you run accountable care organizations, which I do, these are very different views of the world versus running long-term care facilities. It's really about how do we draw those together in a much more rational way to deliver better care to people. This was published, this came out of the RAND Group. The RAND Group is a think tank out in California. They do wonderful work, and this is Beth McGlenn, who is a wonderful researcher's work. Now, this was published some number of years ago. And the bottom line of this was, when they looked at a group of people who did have insurance, who could get the right things done, who had presumably the right access, and asked the question of the care that each of you would want to have for yourselves and your family, what % of that care actually gets delivered? And unfortunately, it's a little bit over half. Now, I think today we're probably somewhat better, but I don't think we're anywhere close to being near 100%, which, if it's our family member, is what we'd want. So how do we drive that? And again, these are the questions, even when people have insurance, even when it's there and available to them. How do we activate them, which is what I'll kind of end with, to go get what it is they need, to become part of the solution, to become part of the equation. This is our curve. You've seen it. This is unsustainable. It can't continue like this. You can't have a GDP that has a quarter dependent on a single sector. It's simply not a sustainable model. And so I think that's where you've seen the focus in the United States around, we finally have to go do something different. We can't keep doing what we're doing. Now, what does it mean, to the individual? And this is a slide I used to show going in 2009, just looking at the difference on the top between health insurance premiums and inflation and workers' earnings. So what does this slide remind you of versus the first lecture? The curve, your curve, is about the same as this curve. And that's the increasing delta and the lack of affordability for all of our patients to be able to engage in health care. Now, one would say, this can't keep on going like this. It's impossible. You can't just go up and up and up and up. But here's 4 more years. Look at the curve. Like your curve, the curve hasn't changed. So we have to do something different. It simply isn't good enough. So the quality isn't good enough. The price point and the efficiency isn't good enough. We've got to do something different. We have to do it. And so that's the call to action. Now, here in this country, and particularly in this state, I saw where, you're talking about co-payments, co-insurance that you're bringing in. which is a way to engage people. As soon as you have to start to pay for things yourself, you begin to think in a much more robust way about what it is you choose and what you do and how you hold people accountable for doing it. So this is what we see in this country now, where I think the numbers are close to 1,500 and 3,000 for a single and a family. That's what, in a high deductible health plan, you would have to pay out of pocket. And then the rest begins to be paid to a high degree by a company or by the government. This is increasing. And a key metric is this one down at the bottom, where when you do this, when people have to think about spending money, costs go down. Now, what we have to ensure is when that happens, that people aren't not getting care. So we've got to concomitantly drive down costs but drive up quality. And the good news is it's possible to do that. Now, for whatever reason, for those of you who have spent a fair bit of time in Ohio, we're on the list of the 50 states. I don't know why that's the case, but there's just greater penetrance of these plans here. And what you see is across the country, I mean, there's just an ever-increasing number of people offering these plans. So this seems to, at least in the United States, be the way that things are going, where costs are beginning to shift more to the patient rather than the employer or the government. Now, this is a particularly interesting slide that I've always enjoyed, and it looks at the difference in some key market sectors, and I think is part of why you see this unsustainable curve. So in the one, it's the service industry. You know, there's been, and it really looks at productivity growth. It's how have these industries really began to become more innovative and do more with less over time. Manufacturing, think about televisions, think about computers, you know, it's really picked up steam. These industries are doing great. Where's healthcare? That's healthcare. Today, more than ever, there's a need for innovation in healthcare and what we do. It's why having the conversations that you're having today are so important. We can't keep doing what we're doing and expect that we're going to get different results. We'll get similar results. The curves won't be different. We've got to tie it together differently. And we've tried it all. I mean, in this country, we've done all sorts of manipulations, by the way, mostly independently, to try to change the cost curve that have, by definition, and what I've just shown you, failed. Now, the challenge is, and the key to it is, we've largely done them independently. We haven't done them cohesively. So as you begin to think about the power of an integrated electronic medical record and what that data can bring to you and what it can help you do over a care continuum to connect the dots and to do this in a cohesive manner, that's the power. And when you quadrant these, we all have to drive to value. We all have to drive efficiencies. We all have to drive quality. We're trying to be top quadrant. So whether you're running national health care in Taiwan or you're running a large insurance company in the United States, that's where we have to drive to. High efficiency, high quality, what we consider the dream suppliers. That's the best of the best. And what we don't want is the nightmare suppliers at the bottom where it's low efficiency and low quality and you're not getting what you're spending. And I truly believe to do this correctly, to tie this together in a meaningful way, we're going to have to use electronic infrastructure to drive that. None of us will have the capacity to do it. We won't be able to hire enough people. You won't have enough social workers. We won't have enough case managers, enough care coordinators, enough physicians, enough of anything to do what it is we're talking about. We're going to have to leverage up. We're all making large investments in electronic infrastructure. We've got to squeeze those investments to get everything out of it that we can. And so on this side, It's the electronic health record, real-time clinical data, real-time clinical statuses that nurses and physicians that we can react to. It's feeding that data into a decision support system that allows you to react in real time or look at entire populations and think about how you strategize and configure new efforts to drive population health. And that's claims, it's finance, it's operations, it's feeding all that data in to allow you to be able to react to it. And then the decision support. So you've got to quickly go from this very granular, being able to react to an individual patient level, to being able to think very broadly about populations. And then lots of other inputs that you can choose to put in. And effectors, alerts, prompts, order sets, automated care plans, patient messages, information reaction. And then think about what I said earlier and what we'll continue to say. How do we engage the patient? How do we activate the patient with all of this? Because if it's just us doing it, we're not going to get as much as we need. If we can engage a patient and a patient's family, we're much more likely to be successful. So what's very interesting, George alluded to the fact that we have a number of different ACOs. So Dr. Kakano's right, we have pediatric, we have commercial, we have Medicare, so we span the gamut. That was intentional. What's fascinating about the populations is when you look at these sorts of slides, it's almost always the same. You've got a very small percent of people spending most of the money. Pediatrics, same story. Medicare, same story. It's always the same story, plus or minus 5 or 10%. Now, the good news is that helps us to think about who do we pinpoint, who do we want to connect with to try to make this different. This happens to be for Medicaid. It's almost the same sorts of metrics. All right. So what are accountable care organizations and why would they be able to help in this regard? So we've done so much, and yet we've not accomplished what we need to accomplish. Well, it's triple aim. It starts there. It starts around a patient. So much of care in the past has been based around hospitals or hospital systems or around doctors. This is about driving care around patients and their families as the predicate, as the primary, as the focal point. It was built off a fair bit of work that came out of the physician group practice. I was fortunate to be involved with this when I was in Pennsylvania in my prior position. A lot of the pre-ACO work, a lot of the pre-patient-centered medical home work. And the difference here is this is an insurance product. Patients are attributed in largely based on their primary care provider, not on signing up or joining something. For us, this did come out of the Patient Protection Affordable Care Act, aka Obamacare, that was passed through. It started with Medicare shared savings and the pioneer ACOs. Generally, and I'll show you what this looks like, it's around fee for service still, but with some potential for shared savings. And as Dr. Kakano mentioned, commercial insurers are now getting quite involved with this. Nothing else has worked. There's a reason why they would want to try something new. And just looking across the timelines, the legislation called for it to begin no later than 2012. They just made that. They got it done right in 2012 at the end of the year. It allows them to really begin to perturb the payment models, that they can drive what's going on in the private market, and that they can drive the pediatric programs through state Medicaid, which is exactly what they've done. So why would ACOs work where others have failed? ACOs done correctly are about using the correct workforce. So we want nurses working at top of license. We want pharmacists working at top of license. We want social workers working at top of license. We want people doing everything that they can do and should do. And I would say arguably in this country that has not been the case. and it's a real opportunity for us. Care coordination and reduction of waste. University Hospitals over the last 5 years has been on a journey to enhancing what we do and how we do it. And I would say we were quite good before. 5 years later, we've taken out some $200 million, and we do what we do better. So there were people I remember sitting in meetings 5 years ago saying, we're great. How much can we change this? There's still much waste. There's still much opportunity to think through in a programmatic way how we do what we do, enhance the steps, and put them back together in better ways. Through that, we can drive better health care. That's about our internal processes. It is about patient choices. Again, this is a patient engagement statement. It's about end-of-life care. It's about really having informed choices. Does surgery help? Or are you better off going a medical route? Only a patient can make those choices. Only informed patients. And I would say only an informed patient with a provider dyad can really help make those choices. We need to drive more of that. Chronic disease is going to be a significant issue for all of us as patients get older, as they become diabetic, as people become ever more obese, as people live longer and have diseases we didn't expect them to have. We've got to manage that ever better. We need to make it easy for patients. We need to make sure that they know what they need to do, when they need to do it, and give them the access to be able to do it. And then we have to have the data to be able to drive all of this. So ACOs are about taking all these pieces and parts and putting them together in a package to be able to better manage this. And again, there's lots of pieces and parts. We're not going to own and operate all of this. We're going to have to figure out how to partner better with others. People who run long-term care facilities, people who run skilled nursing facilities, people who run rehabilitation units. It goes on and on. We're going to have to figure out how to coordinate this in a much more rational way and ensure that as people transition from acute care hospital to an extended care facility, to home care, to home, that there's broad connection and that we're doing each of that perfectly, that the handoffs are pristine. The accountability is important. How physicians see this, how hospitals, how integrated delivery systems see this is going to be critical. And so one of the challenges of ACOs is primary care physicians or primary care providers, that's how patients are attributed into our ACOs. But patients may choose to go outside of that. So an issue becomes how well are you connected to your patient? How well do you coordinate it? Because from an accountability standpoint, we're going to be judged against the dollar spent, even if they're outside of our systems. Most of the programs today to create some level of accountability are based around this. So the top line would be where we would project spending to go. And of course, the line keeps going up and up and up, as you saw from the earlier slides. Generally, what we do is we pick a target that's below that. So if it was a $100 million spend that we're predicting for your cohort of patients for next year, we might say, your target is $98 million. Now, if you can beat that, then you'll share in the savings. You can only do that for so long. So it has gotten people interested. We'll show you the slides in a second because the ACO ranks have grown markedly. In the end, it's going to be about total cost of care. It's going to be about some form of capitation that providers will have to take on for responsibility. What this helps us do is drive to higher value, though. It gets people connected, it creates accountability, and it lets us know what we have to do. But look at the number of ACOs. So back when we started, we were amongst a handful of people that were contemplating doing this. Today, it's exploded. So there were some that said this would go away. Why get involved? If Obamacare fails, it'll be gone. Personally, what we said was, this is the right thing to do for patients. We didn't care whether the Supreme Court upheld the legislation or got rid of it. It was a commitment we organizationally had made to high-value care and driving care of a continuum. And I think what's happened now is that's what other people see. That's why they're getting on board. So this just divides up physician groups, hospital systems, insurers, and different than those three, what it looks like. But if I showed you now the next grouping of the last 2 quarters, it just keeps going up. I mean, this is quite remarkable. This is a real change in care delivery for the United States. And look at the number of lives that we're talking about. So now it's darn close to 1 in 10 lives is covered through some sort of ACO relationship. This is regionally what it looks like, and you see areas where there's much more presence, particularly in Southern California, in Florida, in the East, are just areas that, managed care was more prevalent here. It may have been an easier transition for them to go from managed care to accountable care. And then this is what the government has done in terms of bringing forward Medicare, accountable care organizations, and the pioneer organizations. And again, it's just been explosive growth over this period of time. The quality metrics, I would say, as you look, we now have, or we will announce our 7th accountable care organization here in the next week or so. When I look across the different accountable care organizations, whether it's pediatric, Medicare, commercial, employee, largely they're all focused in some form or fashion around some quality benchmarking. So there's shared savings, which I showed you. You can earn those savings, but you have to concomitantly drive quality. And that for us is a big difference. So I think there was a time where managed care was driving down cost, but wasn't focused around quality. Here you can't do that anymore. You've got to drive out cost, and you've got to improve quality. That's value. That's the value equation. We'll skip through this in an effort to just go through some of the time. All right, so what are we doing? We are focused around at university hospitals, this triple aim, high quality patient-centered care. We want to be innovators. We want to take risk. We want to be at the front end of that curve. Now, there's a challenge. You don't want to get too far in front of it because, that can put organizations at risk. But you also don't want to be at the tail end trying to do what I've just described when everybody else has done it, because it's not easy to do. This is all very hard to do. If it was easy to do, everybody would have done it. New models of reimbursement. We're talking to people about, should we be paid differently? So again, in the United States, we're still being paid fee for service largely. You do something, you get paid for it. That creates, unfortunately, a perverse incentive to do more. We want people to do what's right, not more. Right care, right time, right place. And so this is how we divided up population health, increasing preventative care, wellness activities. So again, real focus now around wellness. So, the one end of the curve is people who are very sick and chronic diseases, and how do we manage that? Well, we need to do that and do that better. We also need to keep people from getting diabetes and from getting illnesses that they can avoid. We need to coordinate the care. We need to drive people to their primary care physicians. Unfortunately, too much care in the United States is driven by specialist and subspecialist, high-dollar care. We need to change that. We need the patient and the provider, that dyad that I mentioned earlier, we need that to be the locus of how care gets provided across this care continuum. and engaging the patients and their families and minimizing waste and duplication. And so this is how we see it. It's the patient at the center, always. It's primary care provider, a clinical care coordinator, many of these are nurses, and then IT as that underlying infrastructure to drive that. That's the core. Now, sitting around all of that, it gets very complex very quickly. And that's part of your and our challenge, is tying all this back together so that everyone knows what's going on at all points in time. And unfortunately today, as people transition into different portions of care, long-term care, primary care physician may not know what's happening. I remember Dr. Kakano and I having conversations about patients in hospice that he didn't know what was happening. It had been his patients for years. He didn't know what was occurring. That's not good enough. We've got to tie this together so everyone knows at all points in time what's happening to the patient, and that we engage them and their families as part of this dialogue. We've grown a lot. We started with 0 back in 2010. We're now up to our 7. It's almost 1 billion lives, $1 billion of attributed revenue for the lives. So for us, it's been explosive. We are some of the largest in the country. We're probably one of the 2 largest pediatric ACOs in the country. And, we've kind of weighed all into this. We believe that this is the future. I don't know that it'll be called accountable care in the future. It doesn't matter what it's called. What matters is that it's high value, whatever we call it, and that it's more patient-centered. And how we look at it is from the patient, start with the patient, so it's about case management and individualized care for those who need it. It's about disease management for broad groups of people with disease like diabetes, like congestive heart failure, like COPD. It's then screening campaigns as we look at the data to think about how we drive this sort of activity. It's about aligning primary care and their protocols and doing this with our electronic infrastructure. And then on the top, it's about thinking about broad populations and driving wellness and driving engagement to the right activities like walking and running and exercise and what people eat to help to mitigate what could go on down at the point. We've had to put together a very new and different team of people to do these activities. It's not, we couldn't do what we were doing before and create change. So our RN case managers, it's a different sort of case management. Case management in the U.S., predominantly was hospital case management. The patient goes home, they're on their own. Can't do that anymore. We have to connect the dots. Liaisons, outreach coordinators, people contacting the patients, documenting that, everyone knowing what's been done, what the issues are, so that everybody can read it. We have medical assistants who we've placed in many offices. So they sit in our physician offices, they talk to our patients, they engage them. If somebody hasn't had a hemoglobin A1C in an appropriate period of time, they make sure that they get it. They're calling them before the visits, they're calling them after the visits, they're ensuring that if they got sent to an extended care facility, that somebody's watching over them. We've added social workers, we've added dietitians, which was unusual for ACOs. And then I think pharmacists are a significantly underestimated resource to ensure that patients are on correct medication, that they have adherence, that they don't have side effects, and that it's the most cost-effective use of medications possible. It's a very different team. We are looking at things like stress management and resilience training as part of broad health and wellness. We're looking at what we've called OptiWeight, which is our program for having people reduce weight, optimizing weight. We've taken almost 1,000 of our employees through this program. Remarkable results. We keep running it. And then as we get to the end, I want to focus on this because it's a very important quote. The real caregivers, it's probably not me as a physician. I'm just part of the equation. It's probably not Dr. Kakano. We're just orchestra leaders. People with chronic conditions are the primary principal caregivers. Each day, patients decide what they're going to eat, whether they exercise, and to what extent they consume prescribed medications. We can't force that. This is about patient engagement. It doesn't matter whether you're in Cleveland or Taipei or Moscow, if we don't engage patients in what the options are, why we're suggesting what we're suggesting, we simply won't get there. It doesn't matter what kind of care we're talking about, whether it's acute care, whether it's extended care, whether it's home care, or whether it's wellness. We have to engage them better. So what's the outlook? Well, I think I can safely say, while 3 years ago I thought accountable care might go away, I don't think it's going away anytime soon. I think this probably is a better mousetrap. It will evolve. The legislation will evolve. I think that's all predictable. But I don't think it will ever be the same. And I don't think it can be. I think we're going to have different payment models. I think you're going to have to figure out, what portion gets privatized, what portion stays within government, and then how do we connect that? Can we all be the best at what it is we do? We want everyone being the best. We want them doing what they're core at. And sometimes it's challenging to be good at everything. I think models of how people and how doctors and care providers get remunerated, it couldn't be more important. We need to pay people based on results, not on volume. So those are the things that we're doing. We're literally reacting here in Cleveland and at university hospitals to that. And we're trying to push. I mean, we're trying to lead, and there's a lot of folks that are quite uncomfortable with, what we're doing. But I think, fortunately, ever less so, which gives us market validation for the path that we've chosen. So you can pick your own names for this, whether it's ACO, clinical enterprise, put in your own moniker. The ACO, we do population analysis. We figure out how to get the right reimbursement to the right people for the right things. We're maximizing our ability to take the data we have and make it useful, to make it powerful, to get it in the right people's hands, to engage everybody, to think broadly about populations and how we can best take that to market. On the clinical enterprise, and again, this may be you all, it's how do you drive that individualized care? How do you drive best practice? How do we educate broadly consumers? Ensure the care delivery systems are there. Ensure that the patient outcomes are reported in a way that creates accountability and alignment. And that causes us to constantly improve, to never be satisfied that we're as good as we could be tomorrow. I mean, that's the essence of all this. Because if it's care for us or our families, it can't be too good. I think that's the journey we're all on. So with that, I'd be happy to take any questions. Thank you very much for the opportunity. Again, it's wonderful to see you.
Hello, Dr. Bieber. I'm Barbara Messinger-Rapport. I'm head of geriatrics at Cleveland Clinic, and I want to thank you for your enlightening presentation. I had a question about one of your slides. One of your slides showed the contents of the ACO, and then on the right-hand side it said possible long-term care, rehab, and home health. So in the Medicaid population in the state of Ohio, 7% of the clients utilize long-term care. On the other hand, 41% of the budget of Medicaid goes to long-term care. So I don't know what the percentage is of users in the UH-ACO will use long-term care services, but I suspect that the ratio of expenditure will be similar, as I anticipate it will be similar in Taiwan when they account for the cost, the true costs of long-term care. So can you comment on that? Thank you.
Yeah, so I would say, I'm glad you didn't fall as you stepped away there. I got a little worried. Yeah, it's a lot like the one graphic of Medicare or Medicaid and costs. So, I said it as it relates to populations, pediatric, Medicare, commercial, that, a small group of people spend, a significant amount of money. You're just extending the metaphor to, long-term care, which is exactly right. So the good news for us as people that do population health is, we're not going to be able to touch all the people we need to touch. You just can't. But the good news is you don't have to. But what you do have to do is you've got to pristinely manage that group of people, that small percentage, the 1, 2, 4, 5% of people who are going to spend a lot of money. And then the question is, why are they spending it? And is it truly all value added? In some cases, the answer may be yes. Unfortunately, as I look at many people, especially as it relates to end of life, I would argue, at least in this country, the answer is no. That many people aren't aware of hospice. We, significantly underutilize hospice in this country. We underutilize our extended care facilities. We underutilize home care. People don't know what choices they have. They've been led to think something that isn't true. When they do learn it, they make very different choices. So there was, a wonderful article published, I don't remember if it's a Washington Post, but it's been published sometimes thereafter, Why Doctors Die Differently. And you can pull it up online, and there's a reason why doctors die differently. And again, you well know this as a geriatrician. They die differently because they know what happens. And because of that, they make different choices. How do we make sure that our patients are engaged enough to make those right choices for themselves and their families? So it's a long answer to, I think those numbers are probably correct. And I, wouldn't be surprised if they're not identical in our population. The question is, are we managing all those folks the way that we need to? Are the right things being done? And are there ways that we can enhance the care and reduce the cost? And the answer, almost without fail, is yes. Yeah.
Thank you. Barbara Gage, Brookings. And as a complement to that question that came up, I might point out for our Taiwanese visitors that this is just one ACO. Other ACOs do have rehab hospitals and home health agencies, and even the community-based providers working in the aging community tied in. So that was an excellent example of what's going on in Cleveland. Thank you.
I'm going to be unbelievably provocative because I'm old. I started in this business when I was 26. I'm now 64, and I can say whatever I want. So one of my questions has been, as I look at the ACO evolution, in some ways, to me, it seems as though it's the fox watching the hen house and getting the resources to watch it. Hospitals are not good places for people to be in. So our goal really for everybody is to keep them in the community and keep them healthy. And I'm really excited about the fact that Taiwan has a real opportunity here to do things differently. For 40 years, we've had an aging services infrastructure in this country that has been significantly underfunded, a community-based system where the focus has been on health promotion, disease prevention, early intervention, and care management. Some of us have been doing case management, care management for 40 years. And it has gotten adopted by new entities and has been reframed over and over again, but the folks in the community know how to do care management. So my question is, why the system seems to still be completely upside down? Why are we not having systems that are totally community-based? That the primary goal is to keep people out of higher levels of care. Most people do not live in a hospital, they don't live in a doctor's office, they live in the community. And with all due respect to what you were talking about here, and I just want to build on the geriatrician's comment, this system is being built around a very medical model, adding new case managers, adding new social workers, adding new nurses, when we have had an infrastructure in the community for 40 years that should be built on? And so I guess I asked the question of what is new here. It seems to me that it's just reusing putting new wine in old bottles. And I want the Taiwanese folks to listen and to understand that you've got an opportunity to do something different. You don't have a lot of the infrastructure that we have in this country right now. So that means you can do things differently. You could develop an entirely community-based system where the default is ever going to the hospital. I mean, obviously some people need it, but most people don't. And so just so that we can talk a little bit about this to understand what this all means in terms of systems reform. A lot of what we're doing now is trying to undo horrible things that we've done over 40 years. And my notion right now of a lot of the transformation is we have chairs on the Titanic that we're shifting. So I just want to raise that for you guys to think about this as you listen to the struggles that we are going through. And I think theoretically an ACO is a great concept, but I'm not sure it's in the hands of the right folks. And so that's a question for you all. You know, who do you want to be driving your bus? And if you want it to be your consumer, then you really have to think about that. So I hope I've been horribly provocative. But I think it's really important for you guys from another country that are thinking about doing things differently. Then I'll stop there.
Yeah, so I could rebut that for quite a while, as you might imagine. So, I would like to think, again, so first off, I was requested to talk about what we're doing with ACOs, and so part of this is the story about what's going on. I think it's a fair question to think about from where it emanates. So, as a public health person trained out of the Harvard School of Public Health, at some level I have a strong personal and profound bias about how public health should be delivered. I would say, fortunately for our accountable care organization, in part because we didn't start off as an insurance company, we didn't have an insurance company, we were able to build it from the ground up. And with all due respect to what's going on in the community hasn't done a particularly good job in this country, nor have the hospitals, nor have the systems. So in the end, you need to perturb the system enough to do something different. So I think it's a fair point that, what you do and how you do it, in the same way that when I started my ACOs, it was de novo. I wasn't encumbered with any existing staff or existing infrastructure or, frankly, existing governance. I was able to create that literally de novo. And out of the de novo, this is what we've ended up with. I think for you all, it's a similar sort of de novo. So you're putting in an EMR. What do you want it to do? What do you want it to look like? How do you want it to be connected into the community? How do you want to empower the community to be part of it? I think that's all right. I think, unfortunately for all of us, if we sit around shaking fingers at who did what and who didn't do what, it diverts the dialogue from how do we make it different and better tomorrow? So actually, I don't think it is the Titanic. I think a lot of great care gets delivered. I don't think it's optimized. So the thing's not going to sink. Hospitals are going to be in business for a long time, and what's going to happen is care will shift to the ambulatory environment, and God willing, care shifts to the home where it really ought to occur. But I don't think it's going to happen overnight, and I think you do need to make it a transition. So I think, again, for you all, there's tremendous opportunity as you think about what the architecture looks like and can look like, and what the endpoint should be and who should be doing it. And to maximize each of those as you go through that process, and to never be satisfied that it's as good as it could be. That's healthcare. That's real healthcare.
Thank you. I think What you're hearing here is what we have in the U.S. as a dichotomous system. It's tied to our financing streams. So the healthcare system, the ACOs, has historically operated around the physicians and the hospitals and the supporting services, all funded by Medicare or funded by the tax base by the insurance systems. This afternoon, when we hear from the long-term care people, they'll be speaking largely from the experience of the Medicaid or the Older Americans Act and those funding streams with the services that are funded there. And it's only more recently that the two lines of thinking, the two sets of experts, the two sets of operations are coming together to develop accountable care organizations. So it kind of takes me back to a question I had with this morning's overheads. It sounds like Taiwan is keeping the medical infrastructure and the long-term care infrastructure separated, which as I was listening to that, I thought, they're going to run into the same issues that it's taken us so long to move towards a person-centered system to support the person, whether it's with their medical needs or their chronic needs or their social support needs to keep them healthy in the community.
Yeah, I think it's a great point. So how do you want to incentivize that, I think is the key. So, the good news now is, whether we like it or not, I think there's certain incentives that are being put forth to drive us to have a different dialogue, which I'd argue, should have happened many years before. But the good news is now it's finally happening. Incentives matter, how you set up the structure matters, which was my earlier point.
The purpose of today's presentation is to try to integrate acute care with midterm care and also with long-term care. That one single payer system. It's a kind of conception that we try to integrate the whole system. We should emphasize that long-term care is a different category. Long-term care, the definition of long-term care, also everybody know that it's 6 months after the treatment or management. 6 months, usually the definition is 6 months. So if you would like to integrate those systems, you should have some kind of transition area. So now we use your term from PAC, from US, that we probably would extend PAC a little bit so we can have transition from acute to chronic care. And now we are at the try. We will have 1 year's try and then expand to all field. We use stroke as a first priority, and then we will expand to other field next year. So I hope it's work. So that I come here. So I need your input. So of course I would like to thank Dr. Wang and Dr. Gong. They give us a lot of new concept from US. So I would invite Dr. Wang to comment too.
It's never an easy question to answer. I think that's what we're here for. What we like to hear is a different kind of model, different kind of approach. There's nothing, written in the textbooks that this is going to work. I think what is going to work is how does that fit into your environment, and how does that fit into the culture, and what does that mean in terms of your political agendas. I think we learned in the United States as well. And I think this is a good time to think about some of the questions that have been raised. And Medicare and Medicaid take many, many years. So when we start with the post-acute care and move into community care and then push the people from the acute side out. And what we realize is that's the wrong way to do. We should keep the people in the community. If they really need a long acute care, we move them back to the acute care institution care. So today we're going to kind of look at both perspectives. I think the question is if we'll do integrated care. And then one of the questions I think Lisa mentioned is, should we combine the financial systems? We are doing that. I mean, Medicare, Medicaid integration is what we're doing. Do we have two different cards? And one is healthcare, one is long-term care. Do we need one card or do we need two cards? Do we need 6 different benefits or we need 1 or 2? Ideally, we may not go into the one things, but where we go in terms of moving that direction. I think that's what we're here for. I think that, one of the things that I have to say from the SEO perspective, I know why. Because a community organization cannot take that risk. Right? Can you? No, you can't. But a healthcare organization, they're able to take the risk and they're able to change the performance in many ways, which is the largest cost is in the healthcare system, not in the community care. So I think we have to start to balance, what is workable, what is not workable, and what can we do first and what we can do second. So this is a kind of just wonderful. I want to thank you, Minister Chu, set up the overall direction of Taiwan and listen to ACO model, which American is moving into. And then we also hear about there's a community care. We've been doing that for 40 years. And how does community care can help the ACO in terms of moving into the same model. So thank you very much. I think it's time for us to take to the next session.